Join in. I don't have a Flexi Rexy, but I do have a prize at the end. I'm like, we're going to start competing for prizes, right? Now it's the expectation. I'm like, what do I need? Y'all need a money? I need Starbucks, caffeine.
That's crazy. A woman after my own heart.
I don't even have caffeine right now. I get like little eye twitches if I have too much caffeine. Also spasms.
I've had like some heart palpitations from drinking too many.
Yeah, probably that's what gave me that one. Alright, so I like these because it's a good preview. See what you know, see what's coming. It helps us to see where you guys are with this stuff. So are you ready? I know, it's serious. Timing. Which part of the digestive tract absorbs 90%, this is more trivia, 90% of the water you ingest? Small intestine, yeah. Okay, so yes. 90% of it is absorbed there. So the colon, that's their primary job, is to absorb the rest, the remainder. It's water and nutrition, yes. Let's keep it going. Oh, and now you review. Ileocecal valve, where it is. I tried to get the biggest picture in there for you. Oh, do you remember? What's the ileum? What's the cecum? I got the bowel disorders lecture this week. Let's see. Ah, hey, some of y'all are just, I don't know. Oh, and I made the area a little bit small. It is kind of tiny. We will talk about that. We got Daddy. All right. The colon is primarily responsible for water and electrolyte transport. Well, we're still kind of split. All right. Maddie's still on top. What is IBS? AKA the IBS. So those of you who've done your reading beforehand, at least 24. A functional GI disorder, yes. True or false? IBS causes physical damage to the GI tract. IBS causes physical damage to the GI tract. It's the other one. Okay, all stuff we're getting to. What triggers IBS symptoms? Your picture's kind of a hint. Anybody else is thankful thing? Show my age. Hey, good job. keep going. What's the treatment for IBS? IBS. You can probably do process of elimination on there. All right, there you go. See, now you're getting it. Leica's trying to get up in there. All right, true or false? IBD can lead to colon cancer. You might have heard this one recently. There we go. Yeah, you got that one quick. Good. We are not moving. What is a common complication of Crohn's disease? There you go. Hey, you guys have been looking up this reading. Is that helpful? All right. We're still not moving. Which age group is often diagnosed with IBD? There you go, we're still getting there. Right. Maybe not what you thought, because you might have heard some who had some of these, so it could be just the lifelong condition. You might have seen in the adult world there of nursing. All right. Usually you guys are flip-flopping with these, so we're staying the same. What's a common symptom of ulcerative colitis? Ulcerative colitis. There we go. Ooh, kind of split. Okay, so that's a misconception there. So abdominal pain is not necessarily present, doesn't mean it's just not the common symptom. It's the bloody stools. Okay. Do you know how it's diagnosed? Rolling right along. How about treatment? So this we're going to get into. We'll just see what you know. So this is another test-taking strategy here too. Should narrow it down pretty quickly. There you go. Some of you might have picked up on that, or you just did that. Uh-oh. Sneaking up on you. Okay, so now we're talking about short bowel. What is a symptom of short bowel syndrome? Have you heard of that? If you haven't looked through your readings. Alright. Yes, so logically thinking through and anatomically what might be going on there. Alright, common symptom of pyloric stenosis. We are switching age groups now. Alright. Alright, four more. Which shape is the mass in pyloric stenosis? NCLEX loves this one, just saying. No hints. I let the AI take that one. I'm like, yeah, I'll leave it. I'll see if they pick it. Oh, sneaking up on you. What is the initial treatment for pyloric stenosis? Good job. Although some of you are a little bit torn between surgery. Initial treatment, right? There's your key word. Still holding strong. What is intussusception? Like my meme. There's a whole bunch of those. Not inception, intussusception. Good read. There you go. Did you get the hint on the meme? I don't know if you could read it. Are we on to our last one? Make a tilted lead. Okay, so true or false, intussusception is a medical emergency. Now that you had the last question, maybe we can figure out this one. It's true. Think about it. Okay, so we're going to get to that. Think about what's going on. Is that it? Here's our last one. But this one's longer. Maybe I'll do this first. What is a volvulus? You're in pediatric GI. Okay. Pictures? All right, who's got it? Nope. Oh, Maddie. Where's Maddie? Oh, there you are. It's nothing special. Maybe next time it'll be Starbucks. Got some Sonic. Thank you. That's a good one. Leftover from a fundraiser. All right. Let me pull up Noel. Okay. So, did know we're doing GO today. So we're talking specifically about the lower GI tract. And what is the lower GI tract? What part of your anatomy includes the lower GI? Say again? Colon. Small intestine. Yeah, that's part of the large intestine. Yes, you're right. Sigmoid and rectum is different. How about up further? What's above the small intestine? Duodenum. Yeah. So it's part of the jejunum and down. It depends on whether you're talking to endoscopy or not, because endoscopy in upper GI is going to get right into the duodenum. They can't reach the jejunum in an upper GI scope. And then the lower GI, they really can't go beyond the colon and the cecum. They can't get through that ileocecal valve that you guys pinpointed on that little map thingy. So, but lower GI, primarily your small and your large intestine and your rectum. So that's what we're talking about here. Primarily the irritable bowel syndrome and inflammatory bowel disease, and what's the difference between the two. So I actually could probably organize it like this for you. So we have GI disorders. slightly lower. And we could branch it this way in IBS and IBD. Because we're going to branch it even further today from there, okay? For those of you who are visual, this is how my brain thinks. I like things in like outline, what's the big picture, what falls underneath it. So we're talking about irritable bowel syndrome and inflammatory bowel disease, and two diseases within inflammatory bowel in particular, okay? So a little bit of an anatomy review. We talked about absorption. Primarily that small intestine's going to absorb nutrients, right? That's their biggest job. And some water, quite a bit, right? But the primary role of the colon, or the large intestine, is absorbing water. Right. If you remember, there's different layers. There's a mucosal layer in your small intestine, and then there's an outer muscle layer. That's important when we talk about one of these diseases. And you know, food passes through the stomach, begins digestion. We have the pylorus here. It's that opening between the stomach and when the stomach empties into the beginning of the small intestine, the duodenum, and then it passes into the jejunum. Has anybody had a patient that had an NJ tube or a GJ tube? Have you heard of that? GJ. Mm-hmm. Anybody else heard of it or seen it or heard it on a report? Maybe they said it and you didn't realize it. So what would an NG tube be? Nasogastric. What's an NJ tube? Nasojejunal. And sometimes there are PEG tubes, percutaneous, through the abdominal wall that has two ports, or an opening where feeding can go in to the stomach, nasogastric, and then at the very distal end of that tube, it's fed through into the jejunum. And we sometimes will do that with an NJ tube if we want to bypass a certain part of someone's stomach for better absorption of medications. So just FYI, I don't know where we would ever talk about that, and because it's not necessarily a lab thing that we do. Maybe when you guys had your NG tubes, was that MedSurg NP tube? You placed NG tubes. Maybe talk about it a little bit then. But also, that would be important to think about if somebody's got one of these disease processes that we're talking about, and we're trying to get nutrients to them. The NJ tube is really just bypassing the upper GI. So it may not be something that's going to be helpful for somebody with, say, Crohn's disease. So when we get to that, that'll make more sense. So just some things to think about as we're talking through everything today. And then here's that ileocecal valve. So the cecum is this largest part of the large intestine. It kind of dips down below where that small intestine dumps into, right? So there's that pouching, and you've got the appendix on the bottom, right? So stool is going to come through the small bowel, and of course this isn't the full length. I should have put that trivia in. Anybody know how long the small intestine is when they stretch it out? That's trivia. It's super long, right? But you also have mesentery that holds it. That's tissue that holds everything into place. That's really difficult when surgeons want to get in there and start making repair to small bowel, because you've got all the mesentery to get through, blood vessels, all those things. So it can be a really complicated surgery. So you've got your small bowel, dumps through the ileocecal junction, or through the ileocecal valve, and then through the ascending, transverse, descending, and sigmoid colon. And out the end. Right? So that ileocecal area, this is important because a lot of people with Crohn's disease, this is where their issues begin. And then when we start talking about ulcerative colitis, they're kind of the other end of the picture. Their disease process starts from the bottom up. No pun intended. Oh, we're talking GI today. I'm just waiting for it. Okay. So this is a busy slide, because I know you all use these to study from. So here's a nice little chart for a comparison. We're talking about 50-50 here. I know when I was learning, I was like, IBS and IBD, what's the difference, right? What's what? They're very different. So IBS, that you know from Kahoot, is a functional GI disorder. So it's in how the GI system functions, so it's not actually causing damage to the actual small intestine, large intestine. Whereas IBD does cause structural damage. And then when we split it between Crohn's and ulcerative colitis, there's a difference within that as well. I don't know if you can all see that, but. So, we're gonna get into more specifics, but you can kind of look through this chart here. Abdominal pain, bloating, mucus in the stool, symptoms with IBS. So irritable bowel syndrome. Syndrome, you guys heard syndrome before? Not the Care, what's that movie? Syndrome, the cartoon. Picture syndrome. Irritating, right? Irritable bowel syndrome. So it causes no physical damage, but there's a psychological piece to this too, as well as physical. They used to think it was a psychosomatic disorder. It was all brought on by mental health. Your gut gets all upset, but they're finding environmental factors can play into whether somebody has a flare-up. So if you're trying to remember those little memory jogger things, IBS, think S and stress. That's the one that has stress, and you can have flare-ups with stress and Crohn's, but this is primarily that psychological. Diet also affects it too, but and mucus in the stool with this IBS. I don't know if that helps you. And then IBD, inflammatory bowel disease. One's irritable, one's inflammatory. So we're going to talk a lot about inflammation. And it's a disorder, so there's named diseases, there's a diagnosis process. Damage is caused, or you do have intestinal damage with IBD as the damage, right? And the bloody stool, so blood, there's more D's in there. Memory joggers, does that help? Maybe? You come up with your own too, let me know if you get good ones. But if you're really thinking through what's happening with each one, you really won't have to do a lot of these memory joggers, right? If you're thinking about inflammatory processes, what's inflamed, what's going on, you won't really have to rely on your memory. Because when you come in and you take a test and you're nervous, that's when all the memory stuff goes, right? You have to go based off of what makes sense, what's logic, what you've stored into your long-term memory. So this is really good to look at to do some comparison. But those are the big things to pull out of this, between the differences between irritable bowel and inflammatory bowel. And there's some overlap in symptoms. So irritable bowel syndrome, bloating and gas is a big one. Right? There's more, there's abdominal pain and cramping. Like I said, you can have the pain with both. I think we were talking about that in the Kahoot a little bit. Cramping, changes in bowel movements, diarrhea, constipation, or both. So it depends on what's going on. And then inflammatory bowel disease, there's your bloody stool, fatigue. And we can logically think through why. So you shouldn't really have to memorize the symptoms if you're thinking about what's happening. So of course we're going to get to that too. Reduced appetite, unintended weight loss. More so with inflammatory bowel disease. Can anybody figure that out right off the bat? If you've got damage to your colon or your small intestine or colon, primarily with IBD. Yes, and it's inflammatory, so you're going to have less absorption of nutrients. Yep. Right. And it also depends what else is going on. Like, do we have blockage? Are we losing? Right? Are we vomiting with a blockage? So we're going to get to some of that too. So let's back up a little to irritable bowel. So this is chronic abdominal pain or discomfort. And then there's this visceral hyperalgesia. So this is where some of that physical piece, besides just the emotional piece, high stress in someone's life, they're finding that there could be, it's almost like an allergy, like your colon or your small intestine gets irritated by things easily. Some people can tolerate certain foods better than others. or medicines or drinks, alcohol. Sometimes those things upset people's stomach. Caffeine, coffee. Some people are just more sensitive, and that's basically what they mean with this term, is they're more sensitive to these things. So if you're stressed and then you're eating spicy food and having caffeine and your guts are all out of whack, this could have something to do with that. Right? You could get a flare-up of your irritable bowel. My husband's a pilot, and he flew with somebody who, they trade off. They fly like hours, long hours, and they'll trade off. So every time I see IBS, I think of the story that he tells me. They're flying, he's a co-pilot or something, I don't know. He had to get up, there's a bathroom in the back of the plane that they fly. And he's like, oh my God, the ibs. I gotta go and run. So he just kept saying, he had to keep going to the back. He's like, it's my ibs. Pilots. Like, all right, I guess, they'll talk about all and anything. So. All right. So altered intestinal motility. So if everything's inflamed, there's two types. You can have the diarrhea type or the type with constipation. Or you could have a mixed, isn't that awful? I was thinking through this, I'm like, should we do a would you rather? Which one of these would you rather have? I don't know. I don't know about any of them. Probably the ibs. Because you can control it. All right, so clinical manifestations. These are more signs and symptoms. So abdominal pain, nausea, increased flatulence. So there's that sensitivity. So if you're not digesting food well, foods that are high gas producers are going to cause more flatulence. Mucus in the stool, we talked about that before. So mucus, ibs. The sensation of incomplete evacuation. So if you're inflamed, your body feels like you've still got stool in there. So even when they go to the bathroom, they might feel like there's still more in there. That's probably the inflammation that they're sensing. And the sphincters that help you go, when there's pressure on them, that gives you that sensation like you have to go. So does that make sense? So you're thinking everything's pushing up on things, it can have that feeling. And like with the Foleys, we were talking about somebody with a Foley catheter, it's pressing up against that sphincter, giving them the feeling like they have to pee. Very similar to this, inflammation and stool. They just feel like they constantly have to go. So that's during the flare-up. So there are times when they're in remission, so to speak, and then there's other times when they're having these flare-ups. And there are some non-GI symptoms. Fatigue. Why do you think? Think if you have diarrhea. Dehydration, right? And it can be tired. What if you have to keep getting up to go to the bathroom? You're trying to get to sleep. Right? Sometimes it's children that do that to us. Sometimes it's the poop chute. Headaches. She's like mid-drinking. Sleep problems, right? Because you gotta keep getting up to go. So there's no known cause. Don't really know. Studies are still ongoing. They're finding, so this is just more information that we have, that some people with IBS have an increased intestinal flora. And so this is that piece where stress sometimes lets that stuff overtake your gut, and then you have these infections. So there's that psychological and physical piece that both go together. So if your gut is sensitive and then you throw stress on your life, you get the IBS. So women are 2 to 2.5 more affected than men. Is that because we're more stressed?
Probably.
We care. I'd love to be able to blow everything off and not let it stress me, right? Right, okay. Psychological stressors can exacerbate it. Family history, maybe. Not so much. But they are finding that, so if there's somebody in your family and then you're showing these symptoms, it could be that. Of course, they're going to make sure you're screened and rule out everything else. And food and dietary intolerances. Now, gluten's in here, but this is not celiac. Those are harder to digest foods. So if you're already irritated, you throw something that takes a while to digest, it's going to cause problems for them. Anybody ever heard the FODMAPs diet or the non-FODMAPs? That kind of gives you away if you've got the IBS. You might already know it. Sorry. Okay, so It's an acronym: fermentable foods, oligosaccharides, disaccharides, monosaccharides, and polyols. So we can get into the weeds with this. You guys are, I would revisit this stuff when you're going through your ATI nutrition. But for exam 1, what I would expect is that you'd be able to pick out like low residual foods, things that are easier to digest. So we're going to talk about that too. But here's some examples, because this isn't going to be the same for everybody who has irritable bowel, right? Some things aggravate certain people's gut and other people are fine. Some people with IBS can have yogurt. Some people need it because it makes them feel better because of the microbiome in there, in your gut. And others can't have it at all because of the lactose. Okay, so these are sugars, right? And fermentable foods, why do you think fermentable? Because what? No, why would it cause them problems? These are foods that cause problems. Say again? Which could be helpful for some, but they're high gas producers. I don't know if I heard that one. So that would be why. So if you've got irritable bowel, gas and bloating is one of the big things in there. So the more gas, the more discomfort you're gonna have. So you wanna stay away from those high gassy foods. Okay. So you can see on this little chart, it kind of helps you with low FODMAP and high. So these whole grains, so this is where that gluten type stuff, the wheat, barley, just takes longer to digest. So if your gut's inflamed, you don't really want things sitting in there, making your gut work extra hard. So this is the time when, yeah, we can have the white rice instead. Brown rice is good too. I like white rice. Let's see, something to know on vegetables. We don't want to give this patient a fresh salad, right? Or raw vegetables, because of that extra fiber in it, it's harder to break down. Nuts and seeds, things like that. Vegetables, obviously we all need them, right? If we peel and cook them, they're easier to digest. So they can have vegetables, we just need to prepare them differently. Okay, we can move on from there. So diagnosis is just solely based on symptoms. There's no physical damage, so a scan shouldn't really, it might show some inflammation, but it's not going to show damage to the intestines. So what are their bowel patterns? How often are they going? What about the character of their pain? What do you think the character of their pain would be? Say again? Sharp, stabby. Gas pain is sharp, right? Cramping is dull. Anybody here have kids and they come up and say, my tummy hurts, and you ask them, is it sharp? Where is it? Point to it. Do that. Is it sharp? Is it ache? Is it if they can point to it, it's usually sharp, and you can pinpoint. It's probably a gas bubble. Give it a minute, it'll go away. Bring the knees up, let them do. Babies, we would do that. Our upset babies in the hospital. Oh, I get to talk to you guys about peds. So we would take their knees up. You gotta watch out. You can't be on one of the ice selects where their butt's gonna point right at you when you do that, because you might wear it. It may have liquid and air coming out. So we could bring their knees up, or like you might hold them on their belly. Moms here ever have a colicky baby? You put them on their belly, hold them like a football. That pressure on their gut helps that gas move along. So, side note. So, gassy. Let's see. Health history. Psychological factors. You've been under a lot of stress lately. Everybody, doctor always asks them that, right? How's your stress level? They should. It's important to talk about. Family history, drug history, what medications, other medications that are causing GI upset for them. Maybe we can switch some medications around. What's their diet like? So pretty much for all of these patients, we would want them to keep a food diary if we're trying to pre-diagnose, especially if their diagnostics are coming out clean. No pun intended. Oh. So yeah, a diary, a food diary is a really good, that'll help the nutritionist figure out, because again, certain foods aggravate certain people. You know, some you can tolerate, and then the next person with IBS might have a problem with that one. So we need to look at when they're having stools, when they're having problems, when they're having pain, and does it correlate with something they just ate? And what's the impact on their quality of life, right? Of course, we do the diagnostic tests because symptoms are very similar to other GI disorders, and we want to make sure it's not something more serious or something that we need to surgically correct, so on and so forth. So there is this diagnostic criteria, the Rome 4, okay? And what they're looking at here is presence of abdominal pain and discomfort at least 1 day per week times 3 months. There's your chronic piece, right? Everything, when is it chronic? When it's over 3 months, right? That kind of goes with anything you hear chronic versus acute. And associated with 2 or more of the following criteria. Change in frequency of stool, change in form or appearance, and that might put them in that constipation or diarrhea category, because you can have one or the other or both. And then of course the other GI and non-GI type symptoms that fall within IBS. The Bristol stool chart, yay, you guys seen this? Sometimes it's they have the picture in your electronic charting in the hospital. So if you need to see the picture, you could pull the picture up. You might have to click on the chart and it'll pop up. Sometimes it's right there in the record and you document what type you saw. So anytime you assist a patient to the bathroom, we're gonna chart that they had a bowel movement, large, small, medium, and what did it rate on the Bristol stool chart. Not the Cheryl Bristol stool chart, poor thing. Would stick to have your last name match the stool chart. So, type 1, like rabbit pellets, right? Super dehydrated, right? Really dry, lots of water absorbed from it, all the way down to type 7 where it's extremely liquid. And you could measure it in volume. So where is normal? What type is normal? 4. They might count 3 and maybe even 5, so it can be in a range. So, like I said, either constipation or diarrhea, mixed or unsubtyped, which is a form of mixed, really. Okay, so males and females have different experiences. So males with IBS are more likely to have the diarrhea, hence the pilot running to the back of the plane every now and then. It's kind of less likely to seek help. Men don't really like to talk about that kind of thing. This is generalizing, of course, not everybody's this way. But females affected 2 to 2.5 more often than men. The IBS-C, the constipation type, is more common in women. Women report abdominal pain, gas, bloating, fatigue, and depression. Again, I think sometimes we're feelings in our sleeve and we talk about that stuff more. It's the culture, maybe. Okay, so no single effective therapy. Again, this is why that food diary is really helpful. We're gonna look at changing stress, psychological support, cognitive behavior, stress management, dietary changes. So all of this you can kind of do together, or if you can pinpoint what it is, change their diet. If they're not feeling stressed, it could be strictly diet related. And we've talked about what we avoid. So if, depending on what subtype they might have, constipation versus diarrhea, we want to increase their fiber if they're constipated, right? But we probably don't want to you want them more hydrated to kind of soften up that stool. The fiber helps them pass that stool. The low FODMAP, which is basically, you might see it on a dietary order as a low residual or low residue diet. That just means not much is left over after the meal is those first few stages of digestion occurs. So easy to digest foods. And then the medications are just going to primarily help with their symptoms, right? So preventing the flare-ups, reducing stress, reducing the trigger, and then treating the symptoms with medications to help them get through that. So fiber supplements for the constipation type. And we don't want to go right to medications or supplements right off the bat. We can fix it in their diet. So if the diet fix isn't helping them, we can give a little extra support with those supplements. Everybody knows Miralax, polyethylene glycol, right? You look that up for clinical NP1 probably. That is a laxative. That is one we used to not give in kids because it wasn't studied on children. The initial studies were all given to adults, so we couldn't give that to kids. Now we give it all the time, half a cap, all the time. So I'm like, I hope there was a study, but I did have some doctors that I worked with when it wasn't studied in children yet. They're like, just give them half a cap. I'm like, you're not supposed to do that. So lubiprostone, this IBS specific, increases that chloride-rich intestinal fluid secretion so that they can then pass that stool a little bit easier. Okay. And the linaclotide, or Linzess is easier to say. Say yes to Linzess. Remember the commercial? I do have the commercial. So I want to put this in here because you guys have heard all these medication ones. So you guys are able to pick up on some things as they talk through here. So maybe we're not. Pause. Let me see if I got some volume. I don't have volume. I was going to blast your ears. We had volume earlier. This doesn't look like a commercial. Okay, well, I'm going to skip that then. That is not the commercial, so the link is not the same. All right, well, they go through and they talk about all the different side effects. Tell your doctor if you have diarrhea. So what would be happening? So if we have, let me go back one more. Increasing chloride-rich intestinal fluid secretion, and now they've got diarrhea while they're on this medication, it's working too well, right? So, you hear the commercials and they're all talking about all these little side effects. You can understand what's going on when you're hearing about that. So that kind of helps you learn some medications as well. So you understand the method of action and what it's actually doing. I know it gets complicated when you're talking about chloride. Well, you have chloride losses when you're losing water in your stool. So this is increasing that fluid secretion back into your stool rather than absorbing all that extra chloride or wasting it all. And that helps motility. It's just another way, Miralax helps slow down that absorption of water so that stools can be softer to go. So this works just in a different way in that secretion. Okay, so. Okay, so for the diarrhea side of things, we've got loperamide, so that's a standard anti-diarrheal medication. That'll give them for their flare-ups for these. The rifaximin, why do you think an antibiotic? Increase microbes, right? So that's that intestinal flora too, so we can give antibiotics that'll actually help control some of that. We have the opioid agonists. That actually might help because opioids will slow down your gut. So it's not usually our first go-to, but for intestinal motility, in diarrhea, it's the colon could be spasming and sending that stool too quickly and not giving it time to absorb any of that fluid. So if we throw an opioid agonist in there, the side effect from those opioids slow that peristalsis process down and gives the colon time to reabsorb some of that water. Okay? So it's for the side effect of that medication. So really, it just binds to the receptors, it doesn't give them the opioid high. So like an agonist, instead of an antagonist, it opposes, so it activates that receptor. And then there's aldosterone. This one though, it says drug alert here, but there's a recent update with that one. It used to be that a prescriber had to go through a certain class to order this medication because of decreased blood flow that can happen, like an ischemic colon on this medication. And so they'd have to go through this training on it, and there was a stamp that they would put on the physical prescription that showed they had that training. So it's kind of like one of those badges you can put on your LinkedIn profile. It was kind of like that, but in prescription form. So only certain providers who had that training could prescribe this. That went away. Now everybody can get it. You wonder, okay, well, why, right? Like I was saying with polyethylene glycol, it's the studies. They found that happened in the initial study, and in all of the repeated studies, they didn't see it happen anymore. So they're not really sure why it happened initially. And it's only given to women because only women were studied. So that's why. It's not for any hormonal reason, it's just because women were in the study for it. I know. So that's for inflammation. Okay, so other things we can give, the antidepressants. So if it's not a lifestyle change that we can make, sometimes we need medication to help reduce some of the stress that's inducing these exacerbations. Antispasmodics, anticholinergics, probiotics, as we talked about. Even that peppermint oil is in here too. Sometimes they found that helps with inflammation. And so there's capsules that can be taken. Again, this is not FDA approved, but some people find that helps. Okay, so IBS, we're good on the IBS, right? Inflammatory process. So IBD, inflammatory bowel disease. Chronic inflammation, so it is chronic. Inflammation, there are periods of remission and periods of exacerbation. So a lot like in IBS, certain periods of time where things can aggravate the colon a little bit more, but this one is going to cause some damage to their colon or to the small intestine. So we have ulcerative colitis and we have Crohn's disease. You guys have heard of these? Has anybody had a patient with either one of these in the hospital? I personally don't see, I've been peds for a long time, but I personally don't see it as much. But you may have a patient who has a history of this and may have certain things we need to consider with them. They could be in the hospital because of some kind of infection or maybe some kind of bowel damage or surgery. Because a lot of these people can be managed outside of the hospitals when there's a complication that they get admitted. Okay. So ulcerative colitis primarily is in the colon. It does not affect the small intestines. So we'll start with that, talk about some differences. And Crohn's disease can be anywhere in the GI tract. Primarily small intestine and large intestine, but it can be anywhere. Younger folks usually is when this comes about, teens, adulthood. And then there's the second peak, like when they become an older adult, that retirement age. So family history for this one, for sure. Now, if somebody in the family had ulcerative colitis, it doesn't mean that a family member could have Crohn's. If it's ulcerative colitis, it's usually ulcerative colitis. Or if it's Crohn's, it's usually Crohn's. Okay, so here's the visual for you. This is probably a little more helpful. So Crohn's disease, of course, they're missing some of the small, you got short gut syndrome going on here. So just for an image so you get the idea. With Crohn's, you can have little patches of inflammation in different areas. Usually it's one area at a time, but just this is visual to kind of give you an idea. There's an issue in this part of the colon this time, and then next time it might be on this descending colon, or it might be in the ileocecal area. That's usually where it initiates, where they have problems. But with ulcerative colitis, the difference here is it's going to start distally and it's going to work its way back.
So does ulcerative
possible, but imaging can help them to determine which is which. So Crohn's disease is actually going to affect the entire thickness of the intestine. So if it's in the small bowel, it's going to go straight through that mucosal layer all the way to the muscle. Whereas in ulcerative colitis, it's just on that internal layer of it. So it doesn't usually go straight through. So in imaging, they can see, are we having damage all the way through the layers? They'll look at different views and different angles, x-rays, CAT scans. So as a whole, IBD is autoimmune. Okay? The body's attacking itself. Sometimes there's a trigger, like I was saying, environmental triggers, bacterial. So sometimes people will go into a flare-up if they've had some kind of infection. Infection creates that irritation, and then if you have this disease process, once you start with it, the dominoes start falling. So you have initial irritation from some kind of infection or illness, and that just starts a cascade of worsening of that inflammation, and then they're into another flare-up. Okay, so with inflammation, we know that can cause damage. So here we are, smoking, stress, all these things are not helpful. They can affect flare-up. Diet, refined sugar, fat, polyunsaturated fatty acid, omega-6s. These are harder to digest, again, so it can create some inflammation. So NSAIDs, antibiotics, contraceptives, and these are your risk factors. NSAIDs, why NSAIDs? What do you know about, and what is an NSAID? It can cause GI irritation, ulcers. So yes, there are anti-inflammatories, but they can be rough on your GI system. And so they haven't pinpointed, but there are 200 genes that have an association. So that's where that family link comes in. Okay. So we talked about with Crohn's, it involves all layers of the bowel wall. And because of that, it can create these fistulas, so that's another piece that's unique to Crohn's. So if they've got some inflammation in there, it can create these little pockets. Where the fistulas can happen. So with Crohn's, when they do have a flare-up, so going back to that picture where it can be anywhere in their gut, anytime you have inflammation and then there's recovery from it, they can develop some scar tissue. So it's in that healing process that actually creates a complication for them. So then they get this narrowing and these strictures. That's what this can cause bowel obstruction. String signs seen on imaging. So if they have like a barium enema and you see like thin areas, that's showing that there's a narrowing within the bowel, that where they might have had an area of inflammation in the past and they've developed some scar tissue. So anytime you narrow, just like with your arteries and coronary artery disease, we're talking about the bowel now. We have inflammation, scar tissue, and now the stool has a small area that needs to pass through. So not necessarily during an inflammatory period, but in the recovery afterward, we might watch them for signs of bowel obstruction. Okay. The skip lesions, normal tissue between areas of inflammation. That's Crohn's disease, right? Because it can be at any point, it doesn't follow in a nice little straight line. Okay, so this is not fun. So one area, they might affect this one area, and maybe they have surgery, and then they have a flare-up in a totally different part. So it's very frustrating. You know, they just get over one bout, and then now they've got another flare-up in a different spot. So it's tough. It's hard for that life balance, the quality of life piece. Because you can't just go in necessarily and just remove the bowel, they're gonna treat it as they go until you're left with maybe nothing in the end.
Is that all they can do for it in surgery, just remove the bowel?
Well, they would remove, and we're gonna get to treatment, but they would remove portions if the bowel has died there. So if you have decreased blood flow and now dead bowel, they have to remove that, because if you leave that, that could cause sepsis. So, yeah, so surgery could be, it's usually a later sign, so we try to treat them with medications and all these other things, but we're gonna get to that. But let's go back to a comparison. So that's Crohn's, now back to ulcerative colitis. So it's just the innermost layer, the mucosal layer, involves the colon, starts at the rectum and spreads upward. So there, this little square here talking about pseudopolyps, these little, you know what a polyp is, those little tongue-like projections. This happens from that pressure and that inflammation on that bowel, so there can be an outpouching when there's a weakening in the wall of the bowel. So that's where those little projections come from. So if you're thinking about inflammation and pressure on that tissue, then you get these little outpouchings. So if you've got tissue that's inflamed, you're decreasing absorption, right? So just like any inflammatory process, that tissue is struggling, it's not gonna do its job. Here's just another comparison again. Diarrhea and cramping, 5 to 6 non-bloody stools a day. So non-bloody, you're thinking Crohn's, right? Sometimes you can have rectal bleeding, but that might be because they're more at risk for fissures and cracks. So with that inflammation, if they have one that's more in that sigmoid colon area, they can have some rectal bleeding. So do you know the difference in knowing about where you suspect that bleeding is occurring when you see bloody stools? I hear darker. Forget. Okay, knew y'all knew it. Darker blood in the stool, which it would be harder to recognize, comes from higher up in the GI tract. Bright red blood in their stool is likely something from the rectum or in that sigmoid colon area. So they could have a little fissure in there. You can't see it, but if it's bright red, it's pretty close to that area. So that's where the bleeding would come from in Crohn's disease. You got bloody stools over in ulcerative colitis, so this is different. Right? They have blood pretty much with every stool because it's an ulceration of it, so there's lots more bleeding. And Crohn's, it could be up higher, so it could be more hidden blood if there is bleeding from that. Okay, so weight loss, some over here on Crohn's, some rectal bleeding, weight loss, abdominal pain, inflammation, fever. Okay, they could be developing infection, right? Inflammation can cause a fever even if there is no presence of an infection. Okay. So usually in that case it wouldn't be a crazy high fever, it might just be a low grade temp. And fatigue, again, malabsorption, dehydration, especially if they're having lots of diarrhea. So ulcerative colitis, just kind of revisiting again, bloody stools. There's mild, and they even like stage it in there. Mild, fewer than 4, moderate 10 stools a day, and severe 10 to 20. So now anemia, we might experience some anemia. And why do you think that would be?
Bloody stools.
It's frequent stools, so we're losing certain nutrients, right? Not absorbing the nutrients that help us grow or develop things like red blood cells, right? Which one is that? Which nutrient for the red blood cells? I'm just bringing it up because we did dysphagias. Folic acid helps with cell production. B12. B12 helps you produce those red cells. So we're seeing this here too, right? So that can be another reason for the fatigue besides the dehydration. Okay. I don't have sound, so I'll let go. Oh, maybe I do. Speaker. Not sure which one goes to this room, but we'll give it a shot.
To do this work, you have to love it.
This isn't a joke, it's about compassion.
Let's compare ulcerative colitis versus Crohn's disease. Let's start with a brief overview. Ulcerative colitis and Crohn's disease are both types of inflammatory bowel disease, also called IBD.
This might help you with
They both
for auditory and
involve the
visual stuff.
gastrointestinal tract and are chronic, possibly lifelong conditions. It's important to know that inflammatory bowel disease, or IBD, is not the same as irritable bowel syndrome, or IBS. Now let's look at the core differences between ulcerative colitis and Crohn's disease. Ulcerative colitis is described as a chronic inflammation and ulceration of the colon, while Crohn's disease is described as chronic inflammation of the gastrointestinal tract. Let's look at the locations in which we'll see symptoms appear. Ulcerative colitis affects the large intestines and rectum only, while Crohn's disease can affect anywhere along the GI tract, meaning from the mouth to the anus. But it's important to know that in Crohn's disease, the intestines are most commonly affected. Now let's look at thickness, or how deeply the condition affects the organs. In ulcerative colitis, inflammation and ulcers will affect the submucosal layer or mucosal layer of the tissue, while in Crohn's disease, inflammation is transmural, which means across the entire wall of the organ. If we break apart transmural, trans means across, and mural means the wall. Now let's compare the appearance. Ulcerative colitis appears as continuously inflamed regions with no patches. Like the name suggests, in ulcerative colitis, we see ulcers. You can remember this by the memory trick. Ulcerative colitis, think bloody ulcers. When it comes to the appearance of Crohn's disease, we see something different. We see a scattered appearance and patches of inflammation throughout the bowel. These patches create a cobblestone appearance. You can remember this by the memory trick. Crohn's, think cobblestone. Now let's look at the complications. Complications of ulcerative colitis include toxic megacolon, rupture of the bowel, and dehydration. Because of these things, patients with ulcerative colitis are at risk for hemorrhage or shock related to hypovolemia or low fluid volume. Remember, these patients experience bleeding ulcers which lead to blood loss, where patients with Crohn's disease are at risk for complications such as abscesses or fistulas. These put the patient at risk for infection and sepsis. Let's look at the classic must-know signs and symptoms for each. Both diseases can produce diarrhea and abnormal stools. In ulcerative colitis, diarrhea may have mucus, blood, or pus. But in Crohn's disease, we see steatorrhea, or bulky, frothy, pale stools. Other symptoms include abdominal pain, weight loss, and nutritional deficiencies and electrolyte imbalances. These can be caused by a lack of vitamins and nutrition and excessive diarrhea leading to imbalance. And lastly, these patients may experience fatigue. Let's look at how these conditions are diagnosed. Both are diagnosed with a colonoscopy. This procedure is an invasive but common test where a scope is inserted through the anus to visualize the walls of the GI tract. Now that we looked at the differences between each condition, let's look at some similarities. It's important to know that there is no cure for either condition, so surgical interventions are to help symptoms. An example would be a colectomy. Ulcerative colitis and Crohn's disease are both forms of inflammatory bowel disease, or IBD, Remember, this is not the same thing as irritable bowel syndrome or IBS. Both have causes that are not completely known or understood, and both lead to an increased risk for colon cancer. Now let's look at some diet modifications patients with both conditions should follow. We want to decrease fiber, increase protein, increase calories, and increase fluid intake. We want to encourage small, frequent meals because these are best to avoid overstimulating the GI tract. Now let's do a final review comparing the most commonly tested on for ulcerative colitis and Crohn's disease. Ulcerative colitis affects the large intestine and rectum only, where Crohn's disease can affect anywhere along the GI tract. Ulcerative colitis is inflammation that runs through the submucosal or mucosal tissue layers, where Crohn's disease inflammation runs transmurally or across the entire wall. Ulcerative colitis appears continuously inflamed with ulcers, where Crohn's disease appears as scattered inflammation and a cobblestone appearance. And it's important to note that there's no cure for either condition. We want to educate them on diet modifications such as decreased fiber, increased protein, increased calories, and increased fluid intake. That's all for ulcerative colitis versus Crohn's disease. If you want more videos that are not on YouTube, check out Nurse in the Making Plus. This includes access to our growing video.
Lots of good resources. So just another way to reiterate everything and put it visual for you. Nice comparison there in the video. I can post that in Moodle too. It's also in the presentation. But that helps you with that comparison and knowing the difference between the two. And understanding pathophysiology of what's going on can help you work through the symptoms and what you would expect to see. So questions? Oh yes, go ahead.
So in the video it said that both of them increase risk of colon cancer?
Yeah, it says both of them increase, but it's ulcerative colitis that's typically the one that would increase the risk for colon cancer because it's primarily in the colon versus Crohn's, which tends to primarily be in the small bowel. And that's that inflammation and the polyps that develop from the ulcerative colitis. Okay, so there's a little more clarification on that one. But good question, good catch. Questions that you might be asked in the NCLEX or exam are likely those basics on the diet. So when you're looking at diet choices, what is going to be easier to digest? What's going to follow that food map type diet, low residual diet, easier on the stomach, less frequent meals. So those comparison charts are really good in knowing the difference between the two. But does that help? Kind of visually? That's the thing. Just because they're both inflammatory diseases, it's tough to know the difference between the two. But those are your biggest differences. With that, let's take a break. I know I kind of went over your hour here, so take a 10-minute break, come back 25 after.